This was our initial model when we started back in 2014, just before we got the Prime Minister's Challenge Fund. We got the practices and the providers together and said, if we're going to have an out-of-hospital model based around primary care, and that whole continuous journey between secondary and primary care, hospital without walls, all those sort of statements, we had to have a model that looked like whatever happened to the individual practices, we had a sustainable, definite area where that people could be seen. So that we set up the 6 hubs in existing practices around the city, and they run alongside 8 to 8, 7 days a week alongside the normal practice. But within that practice we have GPs, nurse practitioners, HCAs, physios. We did have mental health workers at the start as well. And we're starting to put some additional resources in from some of the community providers. So the Coast service, podiatry, and we developed our physiotherapy MSK service, which is a primary care service. Over the course of the first month, Mike developed the IT and a shared telephone system in all the hubs that the practices could book into, and we could see all the patient records. And we built in the capacity that meant, as we developed the services over the forthcoming 18 months, we had resources that meant that different providers could have different direct access to the hubs to develop their services, to run them alongside us in the hubs. To underpin all of this, we had to have a system that meant not only was we had additional capacity to general practice, but when there was a surge, sort of winter pressures, the additional multidisciplinary team could provide additional resource out of hours and in hours. And also the workforce could move between the federation, so our 8 till 8 service, and practices. So we developed a training college that all sectors can access, and that's all the statutory mandatory training, and that was accredited by the LMC and the RCGP. And we've built up our chambers of nurses, doctors, HCAs and our physios, which we can lend out to practices. They can buy them off of us if they need them just for a short space of time, chambers, and we do their PDPs and their appraisals. And then within that team we've got a central admin team that coordinates all the appointments, all the admin, all the data, but also that's the team that does the preparation of all the bids to look at contracts. If we look at the way we started working with the providers into the hubs, initially in practice, if paramedics attend our GP and decide they're not going to convey, they would ring the practice and it would go through to the duty doctor. So we carried on that service in the evenings and at weekends. Paramedics can ring into the hubs. We've got access to GP records and we'll give them advice or a script. 111, the non-urgent dispositions, so the scripts requests, the 4, 6 and 12 hour dispositions come through to the hubs, not to the out-of-hour provider. And ED and our MIU can actually, if you see a patient and you say you shouldn't be here, you should be seeing your GP, they can direct them out of ED and MIU back to the hubs in the evenings and weekends. Or if you want them followed up for something after they've seen them for a long-term condition exacerbation or a dressing, they can book them into the hubs for any time in the future. Now the daytime capacity, there's no GPs in the 8 till 6:30 core GMS time Monday to Friday, but there are nurse practitioners, physios and HCAs. But during the winter pressure times, we put GPs and nurse practitioners back into the hubs to pick up provide the resilience and pick up the surge. And then at Christmas, we share our resources, which is with the out-of-hours provider. That's the time that nobody really wants to work, and although the demand goes down during the day and up in the evening, we condense it and across the city agreed which bits would be open to represent everyone, rather than us all trying to put the workforce in. For the community services, we're looking at interoperability. Originally we had the MIG, and then we moved to having EMIS and TPP running together, but we've got access to some of the records. We've now got a contract for the enhanced access to primary care, so we've developed a multidisciplinary team of OTs, emerging placements, physiotherapists, a dietitian, doctor and an advanced nurse practitioner that look after the 15 care homes that have got the greatest admissions and call-outs and conveyance to ED, and also the largest number of acute visits from GPs. And that team now look after those patients and do all their long-term condition reviews, their medication reviews, and we'll see them and do a modified complex geriatric assessment when they have any change in their either social circumstances or their medical circumstances. And that is backed up by the new service, which is the acute visiting service for GPs during the day. So we have anywhere between 3 and 5 GPs that cover the whole city during the day. As long as the practice rings in before 11:30, they can book their at least 2 visits per practice in, and the team will do the visits for them and write back into their notes, and they've all got mics arranged at the IT that goes out with the GP, so they can write directly into the notes and goes back to the GPs. The reablement and urgent response service from the hospital and the community have links directly to the hub, so they can ring and say your nursing home team needs to go out, or so your care home team needs to go out, or we want a follow-up visit, or this patient's just been discharged, can we go and do a visit and sort out their medication. And the latest development is our ENT provider and our local community podiatry provider have got issues with organising investigations. They have to send them back to the GP, which increases the workload. So they're going to coordinate back booking in directly into the hubs to do their bloods and organise things like ear syringing or appointment follow-ups, and then get the results and send them back to the other providers, so the GP is taken out of the loop. And the acute service, which is we've got a very large teaching hospital, Southampton General. We've got a dietetics pathway, so we host one of their dietitians in the hubs now. And we're looking at an integrated model of saying if you've had all the celiac and Crohn's ruled out, then you get seen by a dietitian in the community, and GPs can refer direct in for their FODMAP and their follow-up investigations, and also for an assessment of perineal function. We've now, in October the 1st, just started the ED streaming, the national mandate, so we've got a hub in ED now, but that covers Southampton and West Hampshire and any patients that walk in, again linked to the community IT. The beauty of it for the Southampton patients is if you're in A&E and you walk in and it's something a GP could see, you're sent round to see the GP. The GP, we're at pain of death to tell our GPs you treat them like you would do if you're in practice, so no bloods and investigations while they're there unless it's absolutely essential, and then they're then booked back into the hub for follow-up investigation if it's needed, or they're dealt with as it would be in primary care, so prescriptions issued and they're sent home. We've centralised the safeguarding across the city. We've got the named GP responsibility in the GMS contract, so things like child protection competencies, section 42s for adults all come into the central hub point. The central hub admin team coordinate that, making sure the correct GP is on the form, the right practice is asked for the right information, and the right information is sent back to the council for the conference. And that made that there's a national stuff going on about saying GPs, we don't attend conferences and we don't engage in safeguarding. And this part has been going for 18 months now and has shown that actually the reason GPs don't engage is because it's usually sent to the wrong place or the time frame. So we're looking at developing that now to say if we put a specialised safeguarding person in the central hub, we can get that person to then do the report for the individual practices and send it back once the GP signed it off.